Hello, this is Fadi Al-Fayoumi. This is the final presentation for the Capstone A project at Washington State University for my project, which is the Vein Clinic. To start by describing the project, I am the medical director of the Heart and Vascular Clinic, where we are taking care of cardiovascular problems, particularly when it comes to the heart and the arterial circulation. And with our new project, we're going to introduce the venous disease management as a new line service for our clinic. To start with a small introduction, under normal circumstances, the veins are blood vessels which are supposed to drain the blood from the feet and the other organs all the way back to the heart. In case of the feet, it's supposed to do that against gravity. And that's being helped and augmented by the action of valves, which are supposed to take the blood in one direction but not the others. In the presence of certain genetic conditions and other acquired conditions like pregnancy, lack of exercise, obesity, and taking certain pills, the valve function can become incompetent and therefore the blood can go back, eventually leading to the distension of the vessels and bulging. This can result in vein problems with variable severity that can range from something as small as that, where it's called spider vein, a bit larger like this, where it's called telangiectasia or spider veins, and it can become bulgy or bigger than this, and that's what we call them varicose veins. The problem with that is that these things can cause pain and discomfort along with the swelling at that level, but that's not the only issue. Down the road, it can cause extensive dermatitis or inflammation in the skin, and eventually venous ulceration can develop, which eventually can lead to infections and possibly amputation. And therefore, clearly the condition goes beyond cosmetic therapy. It's actually a clinical disease that requires attention, early diagnosis, proper prevention, proper treatment, and prevention of complications. The early treatment in the past was surgical stripping. You make a big incision across the thigh and you strip a vein known as the saphenous vein, and you leave those alone in the past. And if you're lucky enough that you have picked up the right vein, then the patient symptoms will be cured. If you are not lucky, and that happened up to 40 to 50% of the cases in the past, then the condition will come back because you just stripped the wrong vein out. With the introduction of ultrasound sonography, the diagnosis of the proper incompetent vein become easier, and therefore targeted therapy toward the disease responsible vessel becomes easier. And with the new technology, without making big incisions in the thigh, we just make a small puncture through a very small needle, we introduce a sheath, and then we induce catheters like a radiofrequency ablation catheter or laser catheters. They go all the way inside the incompetent vein responsible for the problem deep in the thigh. And as the catheter goes inside the vein with a heat induction, clots will form and eventually the vein will shut down. And therefore the blood will find other avenues to go back to the heart and will not go through these bulging veins, and eventually the problem will disappear. You combine this with doing something called phlebectomy. If the vein is very superficial to the skin and you are unable to induce heat by the laser or the radiofrequency ablation catheters because you don't want to burn the skin, you can make a very small, tiny micro incisions and strip the veins out without leaving any scar tissue. And you also complement this with what we call it sclerotherapy, where you inject the spider veins and the telangiectasias with a sclerotherapeutic agent that can actually make those tiny small veins again thrombose or form a clot inside them and just disappear. So all that therapy is done with no big scars, no operation rooms. It's done in the clinic as an outpatient procedures. All of them take somewhere between 20 and 45 minutes. And the results can be amazing. And you can start with something as bad as this, big bulgy veins in both legs, and through the combination of radiofrequency ablation or laser therapy, along with phlebectomy, along with sclerotherapy, you end with something like that. Those are not exactly the same pictures where people advertise of young ladies running on the beach after treatment of varicose veins, but for sure they're at least 80 to 90% better. And therefore, when we build the business model for the building blocks for our vein clinic, between the value proposition, the segment market analysis, the key activities, the key partners, and other building blocks. In the first week, we built the business model. And after that, each building block was analyzed by testing a hypothesis, and that was tested by a face-to-face interview with the customer segments and with the phone interviews with 3 experts in the nation in the management of vein disease and starting vein clinics. So for the value proposition block, our value was to start a safe, state-of-the-art, minimally invasive outpatient procedures that can change people's life by providing avenue for early detection and treatment of vascular disease. And our model was, it is not a spa where you can just come in, inject your veins, and they go away and hopefully they won't come back. No, it was a comprehensive approach, which means that the doctor who is expert in the field will come, will consult for you for free. He will listen to the story, listen to the main complaint, examine the legs, examine the veins with Doppler sonography along with special vein lights to find exactly for your individual case. It is not one size fits all. For your particular case, which vein is responsible for the problem? And therefore, we're going to apply target therapy for this particular vein in this particular patient to make sure we not only achieve excellent results, but we also prevent recurrence. We talked about our customer segments in the second block, and those are the patients who have history of vein disease, history of sudden occlusions in the veins or clots, history of varicose veins, history of spider veins, telangiectasia, people with edema in their legs, even asymptomatic patients who had a strong family history of varicose veins are willing to come and be screened and checked to prevent development of the disease if they are genetically vulnerable for that. And that can be done by the comprehensive evaluation through the history, physical exam, and Doppler sonography. And if needed, physical activities along with comprehensive stockings can be applied for them to prevent the development of varicose veins. When we talk about the customer channels, we propose that the word of mouth will be the best way as a customer channel. The CEO of the hospital came out and suggested that the targeted mail outs where they select people in the community who have been looking for varicose veins or have sought attention or treatment for varicose veins in the past, or based on their age group, based on their sex, based on their medical conditions, they probably have sought for that, and therefore we can selectively send mails to those patients. And one of the gurus suggested that the social media is an important part, particularly when it comes to the TV advertisement along with the newspaper. The customer relationships, the clinic and the hospital, along with the clinic and the insurance relationship was very important, but there was no doubt that the physician and the patients or the staff, the medical staff, along with the patient communication relationship, showing the patients that we are engaged in what we're doing and we are committed to our excellence was the most important part in the customer relationship block and analysis. When it comes to the revenue stream, assuming we're going to start the clinic on only half a day a week in the cardiovascular clinic, we're going to offer the vein services for 4 hours a week to start with. Each patient will require somewhere between 2 and 12 sessions, particularly when it comes to the sclerotherapy for the small veins, because there is a limited amount of how much you can inject per session to prevent other complications that can happen to the patients. Through the average reimbursement, whether the patient is paying out of pocket because that's considered a cosmetic service, or by the insurance payment, we came based on this analysis that the revenue for the year will be about $110,000. We tried to be as conservative as possible in our analysis to make sure that our numbers are legit. In fact, if we apply the radiofrequency ablation therapy along with the compression stockings cost that's going to be given to the patient, and we apply 2 or 3 vein clinics down the road, our numbers should be at least quadrupled when it comes to the revenue. Same as for the overhead, of course, but the potential for that seems to be very great. And we eventually will end with adding a mid-level personnel to help with the sclerotherapy agents, not with the radiofrequency ablation, because that has to be done by the physician according to the state regulations and law. When it came to the key partners, the hospital partnership with the clinic at Valley Baptist Medical Center will help us to reduce the risk and reduce the expenses and improve the marketing strategy. The insurance-carriers relationship is also very important for us to have a very proper documentation, and that's also important for our quality control and for better reimbursement. The medical supply companies, which are going to provide the catheters for the laser and the radiofrequency ablations, the materials required for the sclerotherapeutic agents, and of course the sonography equipment. The primary care doctor and specialist, along with the patient's word of mouth, are the most important partners for this project. Really, the results of the initial patients to be treated there and their word of mouth will be probably the most important partner and continuously be the most important partner. And obviously, the relationship with the primary care doctor's referrals will be considered one of the most important partners. The others are also important, but the primary two will be the word of mouth and the primary care doctor and the specialist referrals. The key resources will focus on the development of quality service and education for the staff, for the patients, to show them that we are engaged, to show them that we know what we're doing. It is not a spa, it is not a cosmetic treatment only if you need it, but it's also a therapeutic, and it's based on knowledge of the staff and the doctors and the commitment to excellence. And one of the experts have mentioned that statement, which I love to put in my slide, that in the face of rapidly declining professional satisfaction and reimbursement in cardiology with the Obamacare and other changes in the healthcare, the practice of phlebology, which is vein disease, can be a useful adjunct. The skill set necessary to diagnose and treat venous disease is well within many cardiologists' training and background. We are cardiovascular specialists. It's the heart, it's the vascular system. We've always dealt with the pump and the heart and the blood going forward through the arteries. And the new avenue of dealing with the blood coming back to the heart through the veins is a new avenue for the cardiologist to be the most well-fitted personnel, along with the vascular specialist, to pursue this as the primary taker of the disease. When we looked at the market analysis, we practice in Brownsville, Texas, which is in Cameron County, the population of which counted, because we have a lot of illegal immigrants, but counted is about 250,000 people. And when we looked at our serviced addressable market, we came with a figure of about 96,000. And we looked at our target market, it's in the range of 35 to 40,000. That's a lot of patients who can be eligible in the lack of any major competition within 20 miles radius in our area. The potential should be very high. And therefore, in our conclusion that cardiologists are well fitted to practice phlebology, vein science, as part of cardiovascular spectrum, the next step will be to work with the hospital to order the equipment. This is a real project. This is not a proposed project just for the Capstone A. This is actually something that I am doing, and I was very happy to apply it in my Capstone A project because I have learned a lot. And not only I proposed it, I actually went through it with my CEOs and my experts, and we already ordered the supply materials for the vein clinic, and we are expecting grand opening sometime in June of this year. Working with the hospital to develop a 6 to 12 months marketing plan through presentations in the malls, having a dinner with the doctor at the hospital for presentation, pursue brochures to be distributed in the clinic and also to be mailed out through the targeted mail channel we have discussed before, television ad once or twice a week for a total of 6 weeks only. And then we're gonna go over the doctor education to maintain a CME, the staff training, develop the proper electronic medical record specifically designed for the vein clinic, and to have the billing process in place. And with that, this is my presentation for my proposed Capstone A project for the vein clinic. Thank you.